I think now I'd like to welcome Gary Phillips back and open the closing part of this particular session with more questions from our esteemed panel to Gary. But before doing that, I'd just like to observe that having listened to what I've heard, clearly fibrosis is such a common aspect of various different types of cancer and even precancerous disease. Whether it's the fibrosis that's causing the primary symptoms, such as in the myelofibrosis cancer, or whether it's in the liver and pancreatic cancers, really interfering with the treatment regimen or contributing to aggressive growth through this dynamic reciprocity process. So it sounds like a really potentially diverse project that could even end up with preclinical or precancerous applications, given the low safety profile. Gary, do you want to comment on that before we open up to the rest of the panel?
Yeah, and I'd sort of joined by Wolfgang to answer your questions as well, because I think, one of the things we recognized early on was that as you said, that the antifibrotic nature makes it applicable to a number of different diseases. And I think one of the challenges we have as a company is to decide, where do we go? We don't want to put this into every single disease where it has a potential, but we've seen from the collaborations that Wolfgang has managed to generate over the last few years that there are some that stand out. I mean, Wolfgang, you've had for examples with the group in Germany, for example, and other areas. I mean, what do you think in terms of the sort of where you should go and what drives selection of which indication?
Yeah, so I mean, you're absolutely right. A pan-LOX inhibitor is a fantastic antifibrotic in any organ disease, as a matter of fact. I think there are some that actually stand out a little bit more. There is fibrosis, for example, induced by radiation, which starts, and you have a defined start date. That one is particularly bad for lung cancer, and we are thinking about running trials in such indication, because you can start actually stopping fibrosis when it is generated. But there are several others as well, for myelodysplastic syndrome that we mentioned already, where we have an interest. Because fibrosis is very widespread, we do need to pick the ones where we can, in a reasonable time frame, actually get to a conclusion, as well as getting a proof of concept that lysyl oxidase inhibition actually makes a difference for the patients. Just one more comment on, as was often mentioned, that how do you find the right patient population? I think we are generating this data as we speak. A part of these clinical trials is that we are getting, obviously, blood samples taken, and we are measuring biomarkers like LOX, LOX2 in the blood, so that we will later be able to associate the disease progression and the effectiveness of the drugs with the lysyl oxidase activities that were present in these patients.
Yeah, good point.
Right. Back to the panel. Hashan?
Thanks, Michael. Maybe a question for Dr. Cox as well as Wolfgang. I think a very important point, Dr. Cox, that you made was around how fibrosis is involved in metastasis and progression of cancer. Can maybe Wolfgang or Dr. Cox comment on what the current research shows there and how LOX inhibition might fit into that?
Do you want to start, Tom?
Sure. Welcome back to the panel. Great question. It's been, lysyl oxidases have been implicated for, I guess, many years now in the progression of solid cancers, many cancers. It seems to have, or at least be implicated in different roles in different settings. There's intracellular roles, there's extracellular roles. I can speak from the context of the work that we've done in terms of extracellular roles, this idea of canonical function in cross-linking matrix. It comes in two parts. At the primary tumor, where you have the deposition of high levels of fibrosis that, as I mentioned in my talk, may block response to therapy, but also may provide highways or routes that cancer cells can escape from the primary tumor and spread. The other is actually in the secondary site. And this is actually quite an important guess, in that when tumor cells arrive at secondary sites, they begin that process of colonizing, and in doing so, activating these matrix remodeling programs at those secondary sites. So in a way, you're getting that same deposition of matrix, that same matrix remodeling, and that same feedback that, to use the term again, triggers this dynamic reciprocity in secondary sites. So it may be possible that even through the treatment with something such as PXS-5505, that you'll be having a direct effect on both primary and secondary sites. There are, as I mentioned, other roles for the lysyl oxidase family members at the intracellular level, and I don't know, perhaps Wolfgang might want to speak to some of those.
Yeah, thanks. I'll just make it very brief. I think there's a beautiful paper actually describing the role of PDGF, and you have heard that in several presentations today as being really responsible growth factor in the growth of cancer. And PDGF needs to be actually oxidized through lysyl oxidase type 2 in oral cancer to be active, and LOX2 inhibitors have been shown to, in oral cancer, to reduce on their own actually the growth of the tumor. And there are several intracellular effects as well on histone acetylation and methylation that also contribute to the anti-cancer effect that have been described, and more papers from collaborators are coming out along that line. So I think it quite nicely shows that there are many extracellular effects in these presentations have focused on, and there are several intracellular effects that still require lysyl oxidases so that the cancer can actually grow.
I guess, should we think about it in the context that, let's say, in order for a pancreatic cancer cell to be able to survive in the liver or the lung, the fibrosis is required to change that environment to make it conducive for that cell to survive? Is that how we should think about it?
That's absolutely one way to think about it. We've a few years ago actually did a little bit of work that we published in breast cancer. It came out in Cancer Research, showing that at least in breast cancer metastasis to the liver, that you require this fibrotic activity or this LOX activity leading to the generation of a fibrotic environment within the liver for those breast cancer cells metastasizing there to colonize. It's too early to say that we can make that direct comparison in pancreatic cancer, but it's definitely something that we are looking into.
Yeah, okay. I'm thinking about future clinical development. Question for Gary. We talked about high LOX and low LOX expressing patients in a number of presentations. If we were to stratify patients on their LOX expression, how would you be able to do that? Would that require tumor biopsy? Would that be a lipid biopsy? And would you want to do that, I guess, in future clinical trials?
Yeah, no, I think Wolfgang's probably, you can explain about the assays and things. It's probably.
Yeah, so I think that is the beauty, that we actually have shown that the increases in lysyl oxidases in the tumors actually are correlated with what you can measure in the plasma. So you don't need to have a biopsy to actually show that lysyl oxidases are high, and there are several data that have already been published, also from other groups, showing that the correlation between tumor progression and lysyl oxidases in the blood is very high. So no, we don't need biopsies. It's a simple blood test that we actually are aiming for to ensure that we could stratify in the future.
Great.
Maybe Dennis, you haven't had the button for a little while.
Okay, thanks very much. Just a more general question, Gary. You seem to have, well, obviously attracted a lot of attention from experts in various cancers for working with 5505. So do you think that that's going to be a key focus for Pharmaxis sort of going forward in the medium term? And I was just sort of wondering about, are you looking at potential applications to non-cancer fibrotic diseases, or are you just sort of likely to stick to cancers for now?
I think that we've formed a sort of a distinction between, the first answer to your question is this: every fibrotic model that we put 555 into it works. So it is a really potent antifibrotic. I think that we distinguish between diseases where we see a sort of ongoing low levels of chronic fibrosis, such as IPF, NASH, kidney fibrosis, where perhaps you want to selectively inhibit LOXL2 or LOXL3, for example, versus the benefit you get from blocking all of the lysyl oxidases in more aggressive fibrotic conditions, such as the cancers. And, I think we've got the advantage of the group that Wolfgang introduced you to at the beginning of this, the publications that they've made, and the fact that they've been seen to be global leaders in lysyl oxidase chemistry and biology has meant that we've had the luxury of opinion leaders and scientists, the ones that you've seen this morning. They've all come to us. So in some way, we're taking this as we're clinically led in terms of where do we think the drugs like to have the most impact on patients, and where do we see the biggest potential markets for it. And certainly with 5505, I see us focusing more in cancer. I had an interesting discussion, for example, with some companies who are focused in myelofibrosis, and they see logical extensions of going from myelofibrosis into myelodysplastic syndrome or other hematological areas where a LOX inhibitor could be beneficial, and that could be quite an attractive step for us, and one that we're able to take because we've got collaborators which are helping us understand the benefit in those areas as well. But the future is not yet written, and obviously some of it is funding dependent as well in terms of how aggressively we move and how wide we go.
Okay, thanks very much.
Bianca, did you have any further questions?
Yeah, I'd probably look at it more from a strategic point of view. You're doing, and you know me quite well, so you're doing hell of a lot of different things, and it's really exciting science, really great. But what is it where you can, for example, accelerate and really put your weight behind it, which to me is obviously myelofibrosis and what you just said about the hematology side of things. What can you do there? And the others, I guess, with many clinical investigators do it that, but it's really kind of to putting that forward and saying like, okay, we really have an opportunity here with combinations. There isn't much for that disease. And we've seen it with Insight that really has absolutely made this company as it is today. What can we do there? What is it that could, what would be the stepping stones to do that?
So two things. So one is, I absolutely acknowledge that, we have a lot going on. One thing we've done though is to explore the additional indications through investigator-led studies. So from a cash perspective, it means that, our focus is myelofibrosis. The cost of doing the other study in hepatocellular carcinoma is pretty low, but we think that 1C will give us some indication as to whether it could be accelerated and we would invest into phase 2. So if we go from 1C or 1B to phase 2, that would be a study that the company got behind, sponsored, and you do it with multinational, multi-center study. Going back to myelofibrosis and Insight and what to do there, we're quite conscious of the fact that this is likely to be a combination therapy in the next clinical study. It could well be that the phase 2B, as we've seen with pacritinib, is actually the registration study, and they ask you to go on and do phase 3 as confirmation rather than regulatory approval. So we are talking to those JAK inhibitor companies as well to see, okay, how do we strategically fit into their playground going forward as well, and what opportunities might that have? So I think we're focused on delivering data as quickly as we can, efficient as we can, which will give us opportunities as a company to decide where we go next and what's the best thing to do. I would really like to take 5505 and explore it both in myelofibrosis and I think in one solid tumor as well. We've heard from Tom this morning about potential benefits in pancreatic cancer, but it's how to find a valid clinical pathway that can deliver results in a meaningful time.
Yeah, great, thank you.
All right, thank you, Gary. I think I'd like to ask, I know we're essentially out of time, but just give me a very brief summary of what you think the nearest term value inflection points are over the next 6 months. And then after that, we'll draw this briefing to a close.
Yeah, I think, we've got 2 studies, one of which we've talked about today, the myelofibrosis study, which, there'll be further announcements on recruitment, and then it's open label. So when we get to, I don't know, a dozen patients that have 6 months of data, maybe there's something there worth talking about at that point. But ideally, we're focused on, something by the end of the year. And then the skin scarring one, which we'll talk about on Thursday, is another one which is recruiting now. It's placebo controlled and a really different, but a very exciting commercial area. which might attract a lot of attention into the stock in the coming months. So I think those are the two things really that people should focus on.
Thank you very much, Gary. And I'd like now to thank Hashan, Bianca, Dennis, and Derek for their patience and questions throughout this briefing, as well as thanking our esteemed presenter, Dr. Hobbs, Dr. Bouchard, and Dr. Cox for their time and detailed presentations. I think it's been an extremely informative session, and hopefully the participants on this session have taken away with it a much deeper understanding of what the clinical trial program and the prospects for 5505 as a treatment are. And look forward to hopefully seeing many of you back here on Thursday to talk about the other side of the Pharmaxis business.
Thank you,
all
Michael.
very much.